I'm Jayati Munshi. I'm a clinical reader at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. I'm a researcher and also a clinician, and I'm a principal investigator for the Social and Economic Predictors of Mental Disorders study. So this is a study where we've linked together information from one of the largest healthcare providers, mental health care providers in the UK, Social and Maudsley Trust, so records from that trust with UK Census, which was conducted in 2011, to bring in missing information into the health records for us to be able to undertake this study. We've known for decades that people with severe mental health problems have really poor outcomes. So for example, we know that they experience life expectancy that's 11 to 17 years lower than the general population. We know that they're much less likely to be in work as well, and so we've known about these outcomes for some time. Prior to doing the study, there was a big gap in big gap in our understanding around how these sorts of inequalities then also played out in for racially minoritized people. So there was a sort of feeling that things could be even worse for these groups of people. In previous work, we've used health records to try and understand outcomes, but health records are essentially generated when people come into contact with services. When they see a clinician, the clinician puts information onto a system. So really the only information that's captured is the sort of information that would get captured during care. And while those sorts of records can be really helpful to try and understand some of the questions that we were interested in, they tend to lack the sorts of information that we really would need to know to understand things a bit better around social circumstances. So, for example, understanding whether people have a sort of migration history, whether people live in houses where they've got adequate heating, whether they're living in overcrowded housing, that sort of thing. So we know that all of these experiences can play a role in terms of mental health, but we don't have the information in health records. So what we wanted to do was link up records from a mental health service, one of the largest in Europe, with information collected routinely during Census, which is a big study that happens every 10 years. And during Census, people are asked about their social circumstances. So we decided to link that information up to bring that missing information into the health record system. The health records that we're using is called CRIS, Clinical Records Interactive Search, and it's essentially all the health records from South and Maudsley Trust, which have been de-identified, so all the identifiable information around people have been removed, and then using a kind of ethically approved process, researchers who've got approvals can access that information to undertake research looking at the sorts of conditions that we were interested in.
I'm Rosanna Hildersley. I'm a PhD student working on the SEP-MD project. So I mostly work doing some of the data analysis as part of my PhD and with the wider project as well. So in the process of linking the CRIS records, the electronic mental health records, with the census records, we did come up with some problems. So we developed, with the ONS, the Office of National Statistics, who hold the census, developed a really robust way of matching those records together, because there's not necessarily a common identifier. You can't just rely on like a name. You have to be quite certain that you're matching the right person in one record with the right person, with the same person in the other record. But when we're doing this, when we're looking at a population of people with severe mental health problems, which is what we're looking at in the SEP-MD dataset, we actually get quite a low match rate. And there's multiple reasons for that. One thing that we speculate is actually that a lot of people with severe mental illness is being missed in the census. That seems quite plausible, and there's other suggestions that might be the case. This is, again, a really big issue because those people are not counted necessarily in the census, and the census is used to allocate especially local authority funding. So the areas where there are people that have this quite significant social care need and are going to require a lot of support and services provided within local government in local areas, they're not getting funded, and that means they're not going to happen. And we all know that local authorities have been really stretched in the past few years.
So my name is Catherine Barrett, and I've been a service user since 1992 on and off, and I have been involved in SLAM's research and King's research for about 13 years now. So that's really been very interesting for me, and also I think it's been important for the researchers because they find that our perspective is useful to move their research forward. I think linking the research to the data analysis and the CRIS database is a great move because you can reach so much more potential and you can reach many more clients and with less of a budget. So I think it's good for PhD students, I think it's good for researchers in general to use the CRIS database. And I think some of the gaps that might cause is some more detail. So you might not get as detailed evidence or information that you need by just looking at a database. I think, you need to speak to people too. So as well as doing the database, you need to do focus groups or one-to-one interviews just to make sure your perspectives are right.
So my name's Ed Davey. I'm Policy and Public Affairs Manager at Centre for Mental Health, which is one of the biggest mental health charities doing research in the UK. Once you can demonstrate there's a correlation between certain characteristics, whether it's socioeconomic or ethnicity or gender or whatever the characteristic is, if you can demonstrate a correlation between certain mental health and other outcomes and those characteristics, and then establish that there's an etiology, then potentially it can tell you really useful things about how conditions occur, how they develop, how people access treatment, whether the treatment is effective for them or not. It can tell you all kinds of really, really useful things. Data's critical because without measuring stuff, without seeing patterns, it's really difficult to change the way things happen in a system like our mental health system. The more we kind of support people to be able to use data and see it and understand it through education, I think it's really important that people have some literacy about the data and what it tells us about the society and the communities that we live in, which is not an easy thing. The better it is, because knowledge is power, and if people understand the dynamics of their community, arming the community with that knowledge, they know it instinctively, right, because they see it around them. But if they've also got the data to back up their argument, that's really powerful.
One of the obvious issues that we're having with the SEP-MD project, it's really amazing the inferences and the information that we're getting, but it is using census data from over 10 years ago. This is partly just because of COVID as a big thing, and other administrative problems meant that it took quite a long time to get hold of the data and to get the linkage in place. So that means that while what we're doing is really important and relevant, actually things have changed in the last 10 years, especially in terms of migration and different patterns of how people live in London. So we can't necessarily speak exactly to the most up-to-date current projects, which is why developing some more readily accessible platform for accessing this sort of data set is actually going to be really important for ensuring the health of the UK in the future.
I think researchers' approach has changed dramatically over the 13 years I've been involved. I think there's co-production now. So So that's a big change, because that's something that wasn't happening when I first got involved.
So this is the first study of its kind, which at scale has brought together mental health records with other forms of routine information from Census. And what we've managed to do is really shine a light on the social determinants, of course, and outcomes of severe mental health problems. So for example, we found in some of our work that being socially isolated plays a role in terms of some of these outcomes in people who've got severe mental health problems, which I don't think has been shown in the same sort of way previously. So studies like ours really add value because we're working with data that's routinely generated when people come into contact with care. We're not having to go out and collect new information. We can work with the data that we have, and we can work with it in a way that effectively allows us to really understand social and other types of indicators that can play a role in terms of outcomes, and that can also then allow us to think about ways in which to target care or think about treatments that might also be effective in improving people's outcomes.